Well, first of all, I'd like to thank GE for inviting me to come and speak and take part in this two-day meeting. Unfortunately, I'm only going to be here for today because I have another commitment tomorrow that I have to be at in the UK. My name is Prof Ahmed. I'm a professor of anaesthesia and critical care at the University of Leicester in the UK, and my day job, I do cardiothoracic anaesthesia and critical care as well. And I'm going to speak a little bit about change management using data analytics. We've heard a lot today from everyone about varying stages of analog to digital transformations that we are taking in our own institutions. And some are fully digitalized, some are fully analog, and most of us are somewhere in between. And what we're going to do is talk a little bit about what change management is, why we need to change, how we need to implement it. So just a little bit about my institution. I work in a city called Leicester, which is 90 miles north of London. It's the fourth largest hospital in the UK, one of the fourth biggest cardiothoracic surgical units in the UK. We take about 1,200 adult surgeries, 1,000 echoes, 1,000 thoracic surgeries, 500 adult and pediatric congenital surgeries, and we've got a 36-bed adult ITU, 6-bed pediatric ICU, and adult ECMO was actually invented in our unit in the 1980s. We do about 300 cases a year, so we do everything except for transplantation in Leicester. This is why it's more famous. In 2015, out of the blue, we won the Premier League, and this is our football club. So for those of you who haven't been to Leicester, it's well worth paying a visit. But a little bit about what we're going to talk about. We're going to talk about the importance of change management in anaesthetics. We're going to talk a little bit about the role of data analytics and how to drive improvements. We're going to talk about people management and the psychology of change, because that is something really, really important that we need to speak about. And then case studies. I'm going to go through a series of studies that we can talk about and how to implement change, and a little bit about the future. So what is change management about? Well, change management is a structured process. An organization is constantly in flux. We look at the organizations that we work in, and the only thing that's constant about the places we work in is that there's constant change. Somebody somewhere all the time is coming up with new initiatives, new product development, new ideas. The latest research comes along, and there are cost initiatives as well. So we are constantly driven both by our managerial teams to improve what we do, be more productive, do more with less, and at the same time improve patient quality and reduce patient length of stay and get patients out of hospital faster, in a better condition, with less resource. And that's a really, really difficult area to work with for us as physicians. But it's fundamentally about a structured process that an organization decides it wants to implement a change, and it creates a position from where it is to where it wants to be in the future. And it involves planning and implementing and resolving changes to an organization's processes, technologies, and values and goals. So change usually comes from senior leadership, and the senior leadership then cascades ideas down to middle management and then to the floor where you and I work. And we are told to implement a certain series of changes in order to improve outcomes that are measured by the organization. And the goal of change management is to help people accept and adapt to change while successfully implementing new strategies and methods. So change is part and parcel of our lives. It's been around for a long time. Heraclitus, the Greek philosopher, said the only thing that's constant in lives is change. And that is still true 2,000 years later in our lives. And currently, the world is changing. The world is becoming more and more digitalized. I've just come from a conference last week in Silicon Valley in the US, and believe me, the world is changing. In the next 10 to 15 years, medicine is going to be completely transformed from the way we have been working in the past to the way it's going to change into the future. But it's something we should not be afraid of. Change is something that, as anesthesiologists and critical care physicians, we should grasp and we should direct ourselves, because if we don't do it, someone else is going to do it to us. And we need to direct that direction of change, steer it, and use the technologies that are coming our way to take the direction and improve patient care the way we wish it to go. Because if we don't do it, other agencies from external governments and other political bodies will. Now, there are many, many models of change. John Kotter is a professor in Harvard Business School, who in the 1990s devised an 8-stage model of explaining why change is needed, how an organization creates a sense of urgency about change and then how to implement it. And that's the model I'm going to talk a little bit more about in detail today. But there are many, many other models. McKinsey's, the consulting group, have got a 7S model that looks at organizational performance using different parameters, and it identifies inconsistencies within divisions, and then it allows the organization to pick up on those and then identify the gaps and then change those and improve the baseline benchmarking that they do, and then look at where they are against the benchmarking and then implement change according to the benchmark. And most of these systems that we're talking about, the Bridges transition change model and the Kubler-Ross change curve model, are all about process management and changing process management. So all of these talk about capturing where we are at the moment, looking at benchmarking and baseline data for where we are, creating an environment about where we want to be in the future, and then how to work through a process of getting there using different models of change. And many of the things that organizations feel that they wish to change, one of the most difficult things to find to change is physician behavior. Doctors' behavior and physician behavior is really, really difficult to change, because each one of us thinks that the care that we are providing is the best care for our patients. And whatever I'm doing is the only way of doing it. And you will find this across the board. We publish international guidelines on the patient management of cardiac disease, management of cancer, best protocols, but implementing those guidelines and the best evidence guidelines is really, really difficult. Changing doctors' behavior is difficult. And not just doctors' behavior, but also within the organization, our managers' behavior is also very difficult to change, because the psychology of change is difficult. People like to be where they are, and they like to stick with what they know. And change for change's sake, which sometimes seems to be the case in the National Health Service in the UK, is often results in what we perceive as inferior care rather than better care and better outcomes. And so people have to believe in what we are going to do and what we're doing. Otherwise, if we don't change according to the way the organization wishes, the end result is actually a huge amount of resource spent, time invested, and yet the results of the patient's outcomes and the organizational outcomes, financial outcomes, are actually worse than they were before they started with. So it's got to be planned properly. And there are several different models, as I say here, that we can talk about. But today we're going to talk about John Cotter's model a little bit later on. And why change? Well, an organization, for whatever reason, decides that it is either not staying up with the competition, or the standards of care that have been redefined by national bodies are not being met, or they have an inspection by a healthcare body like the CQC in the UK. They come along and say, you must do better in certain areas. And when they do that, then they have to implement those changes. And the way they do that is by data collection. We cannot change unless we know what we're doing to start with. And we need baseline data, comprehensive data on our current practices. So in our specialties, in anesthetics, for instance, we need to know in the operating room, to improve operating room efficiency, what time is the patient coming to the anesthetic room, what time is anesthesia starting, what time is knife to skin, why are there delays in the process? Are there delays because the patient's not ready on the wards before they come to us? Are there delays because there are equipments that are not sterilized, or pieces of equipment that are missing? Are the surgeons not turning up on time? Is the anesthetist not turning up on time? Why are the complication rates, in comparatively to different specialties? Why surgeon A, surgeon B, surgeon C all have different complication rates for the same types of patients that they're anesthetizing in terms of Euroscore, for instance, in cardiac surgery? Recovery times and equipment usage. Blood product use, why is there so much variability between physician A, who uses all the blood products in the hospital, and physician B, who does the same operation and barely transfuses the patient? What is the difference in practice and why? And we need to capture that data: infection rates in ICU, renal replacement therapy, lengths of stay. And unless we know where we are to start with, we cannot know where we want to be in the future. And so key thing here is data capture. And then we identify areas for improvement. So within that data, we look at what is it that we need to improve. And this is where I was talking about national bodies, Royal Colleges in the UK, the NIH in the US, NICOR, which is the body that collects cardiac outcome research data, National Health Service, blood transfusion services. But these are national bodies that decide that certain standards need to be met. and define these bodies on the basis of best evidence. So they look at the science, they look at the papers, they look at the clinical research, the randomized controlled trials. We put the best papers together and we assess this, and this takes several times. I'm fortunate enough to be involved with writing some of the international guidelines on best practice in patient blood management in the operating room. And we say that this is the right way of treating our patients, because if we don't, the outcomes are worse and the financial results are worse as well. So once we've done that, we compare the best standards of practice and define those by the evidence-based guidelines, and then we compare ourselves to other units. So Organization X, your hospital, how is it performing in comparison to Organization Y somewhere else, within the same country or within different countries? And we all need to try and improve our practice as to what we're doing. The key thing with managing change is to get people to engage in the process. Because unless you engage in the process, you'll get people who are either trying to implement change from the top, but the people who are receiving the change won't engage and they will not collaborate. So the important thing is to communicate what it is that we're changing and why we need to change. And this is what organizations often are not terribly good at. They state that they're going to make a change, but they do not state why, because they don't state the data that's required to reflect down to the individuals. But communication is key. If you're going to change behavior in an organization, you must indicate what it is that we need to change, why we need to change it, and how our future is going to improve, both our workplace and also for our patients. And that requires collaboration. So you need to engage to all the stakeholders. We're just one set of stakeholders in the operating room. As doctors, as anesthetists, as critical care physicians, there are many, many other stakeholders within the process. There are managers, there are financial officers, there are nurses on the ward, and everybody needs to understand why change needs to take place and to gather suggestions. And often an organization can do something very interesting. Just literally last week in the UK, the government launched a national survey as to how we could improve the National Health Service. And it's open-ended free text web page where you enter data, you enter your ideas, you enter your concepts, and we learn from the people on the shop floor how best to improve things. And often the best ideas come from the people who are working on the shop floor. They don't necessarily come from people who are leading the change from the top, but they need to have influence from the ground upwards as well. And some of those ideas genuinely are useful, others may not be, or may not be implementable, they may not be practical. But nevertheless, you need to understand and survey what needs to be changed. And often the best people to tell you about what needs to be changed are the ones who are working in that environment, not the ones who are working outside. So engaging stakeholders is really, really important, and gathering suggestions. And then once you've got those, then you can plan strategically what you want to do as an organization. So you can set SMART goals up based on the specific, measurable, achievable, relevant, time-bound concept, which sets small goals that people can achieve. There's no point setting a magnificent goal for your organization which is clearly unachievable. It's not going to be achievable because of time, finance, resources. It's not going to be achievable because of the way the organization works. And then if you set something like that, people become despondent. They don't respond to it, and it becomes one of those things that people are trying to change, but people who are receiving the change say it doesn't really affect what we do, we're going to ignore it. So practical, realistic goals are really, really important. And then once you decide you're going to change things, you need to implement training programs. There's no point saying change is going to happen. You need to say what change is going to happen, and you need to retrain your staff. If you could put in a new protocol, for instance, and I'll talk a little bit about patient blood management later on, you need to be able to teach your staff what is the new behavior that they need to do in order to implement and embed that way of thinking and that way of working. Training programs. Within hospitals, we have quite a high turnover of staff. We have junior doctors who are there for short periods of time. We have agency ODPs and nurses and other people who work with us. They come for 6 months, they come for a year. We train them, we spend a lot of time investing capital, time, resource, training these people, and then they leave. And then some new people come along, and you have to re-educate them. And so constantly having a training program in place to keep people up to date is important. The implementation of technology is coming. And whether we like it or not, we have to work with it. I work in an institution which is predominantly paper-based still, but we have been trying desperately to become an electronic patient record. We're partly there, partly not there. In the UK, because we have got a national health service, directives come from the government, and change can't take place in individual institutions. It takes place either across the board or it doesn't take place at all. And as a result of that, managing change is really, really slow in the UK, because whenever a program comes along, and we've had some disastrous failures in the past where universal patient records were being implemented and billions and billions of pounds were spent trying to implement this. The world's biggest companies came along and tried to implement this, from IBM and others. They weren't able to do so because the systems within each organization were in-house, they were created in-house, they were not working very well, and most importantly, they were not communicating with each other. So you need a core standard which can communicate across primary care, across secondary care, and within the organizations themselves. So technology is coming, and when it's there, it should really implement and improve our workflow. Doctors and nurses do not engage in technology and innovation unless it improves their workflow. If you create advances that will hinder what we do, and in my operating room, if somebody comes along with some technology and says, you can use this, this is great, we're going to do this, 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 the first question I ask them, is it going to improve my patient care, and is it going to improve my workflow? Am I going to get better throughput with this technology, or is it going to get in the way of what I want to do? And if it gets in the way of what I want to do, I'm going to switch it off, because it's not going to improve what I want to do, it's simply going to hinder what we're trying to do. So that is key thing. Any technology that comes in must improve your workflow and your productivity. Otherwise, it doesn't work. And cost-sensitive analysis, as always, is really, really important. There's no point implementing something unless you're going to get a cost benefit from it. So the way we implement things, we should implement things, first of all, on a small scale. Do not implement changes on a large scale, because you don't know how they're going to work. Test them in a small environment, test them in one operating room, see what the responses are, and then once you've learned from that, then you can scale up. And scalability of change is something that's really important for organizations, particularly large ones, where they can see that once they've successfully implemented a program in one section of the organization, they can then scale it up across the board. And then once you've implemented a change, it's not sufficient just to implement it. You need to monitor. Is it improving? Is it delivering what you thought it was going to deliver? So if you implement a change in monitoring the operating room environment, for instance, we're talking about care station and so on. Are we collecting real-time data from the clinical decision support systems to tell us that what we're doing is better, quicker, faster, improved patient care? So are we doing more patients per unit time? Are we doing more operations during the operating session? Are we starting more efficiently? Are our patients having reduced length of stay? And collect this data and compare it to what we were doing before. Because if your performance after the change is not better than it was before the change, then the point of implementation of change is negated. However, everybody needs to measure what they were doing before, measure what they were doing afterwards, and then get regular feedback mechanisms and audit the change. So audit what you've done and see whether it makes a difference. And then you can fine-tune the process. So not everybody gets it right first time. You make a change, and you may miss something. You may want to go back and look at that data that you've got and make necessary changes, close the audit loop, and then optimize using more data to look at what it is that you can improve within the processes. And that creates opportunity for further development and refining the process. And then what you don't want is, once you've implemented a change in an organization, in your operating theater, you've got to keep it sustained. What you don't want to do is 6 months later, people going back to what they used to do beforehand. Because if you don't do that, then you're going to get this situation where some people are doing the new thing, some people are doing the old thing, and there's going to be a mishmash of environments, and you won't deliver either the financial benefits that you were hoping that you were going to get, and you won't deliver the better patient care that you're hoping you're going to get if you don't sustain the change. So the way to do that is by regular training, and particularly in high turnover hospitals where staff come and they go and they leave. You've got to have patients who are, and staff who are regularly trained and regularly monitored, and try and retain staff. The first thing you will find is if you implement a change that is not successful, is that recruitment and retention becomes difficult. The staff that you had before will look for other jobs. They will either leave because you made their working environment more difficult, or you made it harder, and you have not shown them a benefit from that change. You've simply made their working environment more difficult. And so the first thing people do is say, I'm going to look for another job. I'm going to go. So recruitment and retention are really, really important. And then embedding the cultural change is also essential. So if you've got buy-in from the doctors, buy-in from the nurses, buy-in from the theatre staff as to implementing a new change, then you're much more likely to be able to sustain it. If people rebel against it, and again, it boils down to whether they believe the change is worthwhile. If they rebel against it, you're not going to be able to successfully sustain that change. And one of the key things about good leadership is that organizational development, support for people to go off and be trained in new behaviors, and also to be able to measure what they're doing. And this concept called compassionate leadership, that's really, really important. So your senior management staff must believe that not only is the change being implemented, but also they have to look after their staff, because if the staff are the most precious resource there are, human resource is undervalued, and particularly in medicine, and particularly in subspecialties within medicine like mine. There are only a handful of cardiac surgeons and cardiac anaesthetists in the UK. There's 350 surgeons, maybe 450 anaesthetists who do this job. If you don't retain them, and if you don't engage with these people, they will leave, they'll emigrate, they'll go and work somewhere else, they'll do other things. So you must engage with these people, and you must convince them that the benefit of the change is worthwhile. And then there are tools and techniques. So how do you measure data analytics? You can measure the electronic patient record, and you can use machine learning algorithms, and we'll learn a little bit about that later, because this is where the future is heading. The mining of data and the improvement of data by collecting data-driven analysis, that's the way the future is heading. You can use dashboards and visualization and process mining, and you can use natural language processing. These are all AI-based concepts that are coming along in the next 10 years. And there is more data that's being collected, and a lot of these, say the NLP models, for instance, are being used to extract data from written patient records. So at the moment, our patient records are very disorganized. If you have written paper records, they have notes written in them by many, many different people. And extracting the information, summarizing that is really difficult. But our NLP models are coming along, and they're able to extract that information. However, they're not foolproof. And this is the other thing, that if we're going to use these analyses and these tools, you need to have oversight as to what is going on, because sometimes what they produce is not necessarily what you expect to find. And if you find something unexpected, the first thing you should do is go back and look at the data and see whether genuinely the change and the issue that you found was different does exist or not. The first rule of monitoring in the operating room is, if your monitor is telling you something and it doesn't fit in with the clinical process, then always look at what's the data coming into the monitor. Is it telling you the right thing, or is it your patient that's the actual final gold standard of your monitoring? And there are varying things that we can use to assess decision analysis processes. So within, with my world, we can use demographics, we can use categorical data, you can use comorbidity, conditions, DVTs, the presence and absence of comorbidities, and all of these things can be embedded into data collection to look at whether we are using the scoring systems accurately. So in cardiac surgery, for instance, we have the Euroscore system in the UK, which gives an allocation of risk. The data is collected by many different sources, so you can do preoperative risk evaluations, and we're not terribly good at that. We get patients into clinic, we measure their preoperative anemia status. We look at what their iron is, what their B12 folate deficiencies are, and yet we don't treat all of these patients. We don't optimize all of our patients coming for surgery. That's a whole area we can look at of pre-optimizing patients, getting them in the right space before they come to the operating room. And this applies to all types of surgery, orthopedics, obgyn, and cardiac, thoracics, whatever. Real-time intraoperative assessment. This is where the key thing is, that in the operating room, if your EMR is connected to real-time data from the labs and from the hemodynamic data that the patient is giving you, then you can start to make accurate predictions as to what is about to happen. And the real thing that's going to happen in medicine in the next 10 years is we're going to change from being reactive, which is what we currently are, to becoming predictive. And we're going to intervene earlier and earlier in our patients, and we're going to be making changes to our patients that little bit more efficiently. So the personalization of medicine is what is coming, and the predictive value of medicine, that's what's really going to change from what we are now to what we're going to be in the future. And post-operative follow-up, again, this is just an example that, you know, a system can hold data on the cloud, and there are Amazon Web Services and other sorts of cloud services that hold all this data. There are issues around where the data is held and which countries it's held in. In the US, there's the HIPAA regulations. In the Europe, there are GDPR regulations. There are regulations within the UK about the anonymization of data. And all of these things are really, really important because patient data is sensitive. Anonymized patient data is what these systems use, so it can't be traced back to an individual. But nevertheless, there are legal aspects around what we do as well, which I'll talk about a little bit later on. And there are many, many sets of data that we collect in the operating room. I mean, we don't realize this, but there are lots of areas where raw data is being collected about the patient from the point they come in, from the point they have contact with the doctors and nurses, the electronic hospital records, the demographic data, the labs, the operating room, the hemodynamic data, the physiological data, the imaging data from the radiology department. All of that is collected around the patient, as well as itemized data such as hospital information, clinical biochemistry, and so on. And all of this data, if it's collected and if it's analyzed using data-driven machine learning systems, will lead to better and more accurate prediction of how the patient's physiology is going to be. And this is where we as physicians are going to have to learn how to manage this data. We shouldn't be afraid of this. The key thing is doctors get scared that the AI revolution is going to change what is going to happen in our workplace. It isn't going to change it, but it's going to improve it. And it will provide us with better clinical decision support than we've ever had before. It's still up to us to make the final decision as to how we treat the patients and what we're going to do with them, but we have better and more accurate information to treat our patients with this. And all of these things are coming our way because this is how things are going to change. So let's talk about implementing organizational change. We talked about these different models, the McKinsey model, the John Kotter model. And I'm going to talk a little bit about in your own organization, if you want to go back to your hospital and you want to change something, how you're going to change it. And this is the model which is called the John Kotter model. It creates a sense of urgency, it builds upon the ideas, it implements those ideas, it enlists champions within the organization to implement those. You then enable those ideas to take place, and then you generate further data, and then you sustain that. And each one of these stages we're going to talk about a little bit more detail now. So Kotter decided that he should write a book that says, it's called Leading Change, it's published in 1995, and it's about changing the psychology of behavior within the hospital. The first thing you've got to do is inspire people to act and see something as an aspirational opportunity. If you do not engage people or inspire them into doing something, you won't get buy-in, you won't get people to change. And in order to do that, you've got to get one or two people to be leaders in the organization, to cascade down to everybody else that this change needs to be implemented, whatever it may be, whether it's behavioral change, whether it's a change in clinical practice, whether it's a change in implementation of analog to digital patient care solutions, whatever. And then you build up a momentum that excites people to be enthused by it. If you're not enthused by the change, again, you're not going to engage in it. So you've got to get people to be interested, you've got to get people to have buy-in, and you've got to get people to understand why making a change is going to improve their working environment. Why is your working environment going to get better if somebody comes along and changes the way you work? Are you going to be able to do more cases in a given day? Is your day going to improve? Are you going to be able to start your cases on time? Are you going to get better patient outcomes? Whatever it is that it is, you must share that vision together with the management team, because if you don't, you're going to get dysfunction amongst the group. And then you have to build a coalition. So as always, you need a bunch of committed people within the organization to lead that change. And that's always a little bit difficult, because often the people who are leading the change are not the ones whose work environment is being changed. And this is where you get resistance from us. If somebody comes along and tells me from somewhere else that you're going to do things in a different way, what's your immediate reaction? You said, no, I'm not. I'm fine working the way I am. I don't need this change. You show me why. And one of the things we struggle with as doctors, just digress a little bit, we talk about evidence-based management all the time. And my answer to this is to turn around to whenever somebody tries to implement a change, says, show me the evidence. There is no such thing as evidence-based management. It's concepts, it's ideas, and there's no proof that changing something actually improves things. You have to make the change, you have to go back and measure, and then you have to go back and demonstrate that your proof was good. But the concept in medicine of don't do something unless it improves the patient outcome is embedded in our psyche so well, the evidence-based medicine, that it's an anathema, it's a strange concept to ask a manager who's implementing change, show me the evidence, tell me how this is going to work. So unless you can get buy-in from people, unless you get people who are committed to demonstrate that a change is work, and it doesn't have to be complicated. They can simply say, in hospital X, down the road, 50 miles away, they implemented this change, and look at what they're doing. They're doing things better, faster, for less money, and they got better patient outcomes. That should be sufficient enthusiasm for me and you to say, okay, we'll give it a go, and we'll change. So you need to get an army of champions. Whenever you change something, you need to get one or two leaders who are inspired by it, one doctor in the department who is going to say, this is the way we want to do things, this is the great way of doing things, let's change around what we're going to do. And let's consider this an opportunity, and we're going to change, because at an individual level, everybody wants to improve patient care, and that's what we all want to do. And if we can't do that, then the change management is not going to take place. So you need champions who are usually dynamic individuals who can speak, who can enthuse, who can engage with other doctors and get them to contribute. And collectively, they must all be unified in the pursuit of achieving that goal together. So that is the next thing. Get a bunch of people excited by the change, and then say, this is what we're going to do, and this is how it's going to improve what we're going to do. And then you enable the action by taking away obstacles. In any healthcare organization, there are so many obstacles, there's so much bureaucracy to progress, to change, that people often give up. Any one of us may go back from a big scientific meeting and say, yeah, great, I'm going to implement this change because I've learned so much about this new echo technique or this new blood management technique, and I want to implement this in my hospital. And then you go back and you find it's impossible to implement, because there are too many roadblocks in the way, there's many, many people standing in the way. You can't do that, we can't let you change this, we've always done it this way, we can't change. And it's getting over that that's really, really hard. And that's the way you have to get these people who are the champions to lead the way and to clear the way for people to innovate. The best organizations in the world allow their senior staff to work without being micromanaged. They allow them to innovate, they allow them to modulate their working environment, and they allow them to create the best way of working for them. If you micromanage individuals, you will get some success, but you won't get the most success. The best success comes from letting the intelligent guys do the work themselves and improve their working environment themselves. And that's what generates impact. And then generate short-term wins. Unless you can show short-term wins and goals, people get disheartened by change. So if you can show that you've implemented something and all of a sudden your patient throughput's got better, all of a sudden you're using less blood for your patients, or the surgical throughput is improved, or your infection rates have gone down, or whatever. Measure them and advertise them widely. Tell everybody what a success you've had. Tell everybody that this change that we did, look at what happened, it improved things. And that way communicate it to everyone, because that re-energizes people to continue with the change. If they don't see a win and all they see is negativity, they're not going to engage and enthuse with it. And then keep the pace of change accelerated. So once you've got the win, demonstrate another win and demonstrate another win. So push harder for more successes. Increase your credibility, embed those structures into your workplace, and then keep pushing for that change until that vision becomes reality. Now, that is not easy to do in an organization that is financially constrained or constrained via human resource, or people are trying to firefight on a daily basis just to do their job, let alone look at the global picture and change things. However, you need people to drive that vision and communicate that vision across. If you can't communicate that vision to people, people kind of forget the big picture. They always focus on what they're doing on a day-to-day basis. So it's really important to get that across. And then make the change. So articulate the changes between what you did before and what you're doing now, and make sure they get embedded into practice. And that's the key thing I was saying, that train your staff again and again in the new ways of change, and make sure that those staff then cascade that down to other members of staff, because you get high turnover of staff within a hospital. The ones you've trained often leave, and the ones who are left behind are the ones who used to do things the old way. And you need to retrain them and keep pushing them again and again. And then make sure you've got systems in place to reinforce that mindset, and the champions are still leading the process. So you've got people invested in the new ways of working. There are challenges to this. I mean, it's great standing in a room full of people who are enthusiastic and who want to change, but nevertheless, implementing those changes for an organization are really, really difficult. You've got to get people to break down working in silos. We all work in silos in hospital medicine. The managers work different to the administrators work different to the doctors work in their own world, nurses work in their own world. And getting integration between those worlds is really very, very difficult. That's what you've got to get across. Break down the barriers, break down the silos, and communicate a common change that's going to implement better patient care. Leadership development. Unfortunately, many organizations have people in leadership positions who are not naturally talented leaders. Not all leaders are in leadership positions are the best placed. They get there for a variety of reasons, professional development and all the rest of it, but genuine leaders on the work floor are the people who lead the teams, and they're the ones who can guide and administer change on a local level rather than on a global level. And you need to engage those people. And once you engage those people, you have several of these people in different departments, you can then scale the process upwards across the organization. Culture change is the most difficult thing. As I say, unless you get engagement and buy-in from the people that you are trying to change, and you can enthuse them whichever way you wish. You can either motivate them using finance, you can motivate them using better patient care, you can motivate them using better improved workflows, whatever it is, but changing culture is the hardest thing to do. And unless you are successful at doing that, your organizational change management will not work. You need to get, as I said to you, those on the shop floor are often the best people to give the best ideas back to senior management, to reflect back, to say, what if we changed this? What if we did this? What if we did this? This would improve the way we work. And often those things are not seen at a high level. They come from the ground up. So sample your staff, get the work that you need from the patients and from the staff, and get ideas. And of those ideas, filter them and rank them and decide what is implementable, what is genuinely going to improve patient care, what is not. And drive the digital technology transformation. So you've got to engage people with the benefits of technology, not just the, oh, here it is again, we've got to change because somebody else has decided we've got to use new technology. Genuinely demonstrate to people how that tech is going to change their workflow and the pattern of how they work. So I'm going to talk a little bit about implementing patient blood management patient blood management is a concept which you may or may not have heard of. It's something that's quite close to my heart. I speak about it, it's my research and academic interest, but it's about transfusion and blood product use in the operating room. If you know, historically, we've had a lot of use of red cells, plasma, FFP platelets in patients who didn't necessarily need to receive them. And because since the pandemic, the resources become rare, people are not donating blood anymore, we have to be much more careful about how we're using blood. And we're using it appropriately in those patients that need it, but also we stop using it inappropriately in those patients that don't need it. And so implementing patient blood management programs is something that's very hot and sexy in terms of the scientific content. I've just been talking about this at the EAPTA-IC conference in Freiburg in Germany just 2 days ago. And implementing how a patient blood management programs was one of the important things that we said, because again, it's all about identifying a change that you want to implement, then how to implement the change. So if you look at the journey, patient journey in patient blood management, we can talk about this bit here, with preoperative screening, and we talked about this. This affects all areas of surgery, anemia screening before the patients come to theatre, optimizing the hematinics and managing blood stock control. So all of these things will financially benefit the organization. In the US, they affect the way the organizations are remunerated from the insurance companies. And most importantly, it's good patient care. And similarly, within the operative environment, in the operating room, how can we improve the way we treat our patients? We can improve the risk, we can predict who's more likely to bleed, we can get better stock control of blood coming into the patient, we can have early warning indicators of aberrant physiology, and allow earlier ordering of blood products. Some hospitals need an hour and a half before they can get hold of red cells, before they can transfuse the patients. Others can get them in 15 minutes. Why is that different across organizations? So you can look at the operative processes there. And then post-op, in the ICU, when your patients had surgery, adhering to treatment algorithms, one of the things we get is a wide variability of how doctors treat patients. Why do some doctors transfuse patients 2 units of blood straight away as soon as they come to ICU, and others will not transfuse them at all when they don't need them? It's because they believe certain things are required, and that is not always guided by the best evidence. So implementing and reducing variability in care, that's what implementing patient blood management programs is about. So if you look at a clinical decision support system, we can identify and risk stratify our patients beforehand. So at the moment, all patients go into surgery, but what we don't do is identify who's likely to bleed, who's not likely to bleed. Are they on dual antiplatelet therapy? Have they got multiple comorbidities? We need to categorize and risk stratify patients. And we use a variety of physiological data and point of care data and lab data in the operating room to decide how they're going to be. But wouldn't it be great if we could look at patients before surgery and plan? Today, we've got 6 high-risk patients coming into surgery. We communicated to the blood bank in advance, we're going to need more blood and blood products today because our patients are more likely to require transfusion. And that allows better stock control for the blood bank. It allows less wastage to take place because blood is a precious resource, it's time limited. If you waste blood, it has to be thrown away. You can't just store it back again. And this relies on manual integration of all of these results. So if you take unified data sets, interpretation, and how to diagnose and treat bleeding, it requires expert knowledge base within physician, which is why we train for 20 years as doctors to be able to treat our patients as consultants, and why no matter what happens, a 2-year trained physician assistant is not going to be able to take the place of a 20 years of experience of a doctor. But people are worried about this. And this is what I was saying. It's a reactive process. The surgeon cuts the patient starts to bleed, they develop a coagulopathy, then we start to think about treating. But wouldn't it be great if we could start to look at the coagulation process and implement it earlier and earlier? And the more complicated decision-making systems that are coming along that use AI, data analysis, and data-driven systems, they are going to look at these data sets that have been produced by the hemodynamic monitors in the operating room, by the point-of-care test monitors, the TEGs, the ROTEMs, and they're going to be able to integrate those and present them in a unified interface on the EMR in the operating theatre to the doctor, say, your patient is becoming more coagulopathic as time goes on, or they're becoming more hemodiluted as time goes on. You need to think about transfusing the patient. You need to think about ordering FFP or platelets. So flagging things up earlier to the doctor makes the final decision. They don't have to make the decision for them, but then on the basis of that, you treat your patient earlier and better. And ergonomically data that's presented to the physician, and that's the key thing, it's got to be easily interpretable. We have a lot of things to look at in the operating room. We look at transesophageal echo, we look at the patient's hemodynamic data, we look at cerebral monitoring, we look at the surgery, we look at everything else. We need to have data presented to us in an easily identifiable and understandable manner. And if that's not done in an ergonomic manner by people like GE Healthcare and others, then those monitors are not as useful to us as they would be if they present data to us and guide us as how to treat patients. So the best value of a clinical decision support system is this. It allows us to detect something early that's about to happen. It allows us to use appropriate therapy for the patients that need it. It also prevents inappropriate therapy for those who don't need it. And then it suggests appropriate transfusion for when indicated. And where can they help us in the operating room, for instance, for transfusion? So if you look at this, traditionally cardiac surgical patients have received blood transfusions when the hemoglobin goes below a certain threshold. In my world, there's a big debate going on over liberal versus restrictive transfusion thresholds. But generally speaking, most patients get transfused when they're around 7 or 8 grams per. However, looking at the data analysis and looking at individual personalized data, it will allow us to decide earlier. If you've got an 80-year-old patient who's got comorbidities, who's got renal failure, who's got other things, it's probably better to transfuse them earlier and more aggressively than it is for a patient that's fit and well, that doesn't need, has got better, stronger physiology, and the type of surgery they're undertaking. So these systems will be able to guide us a little bit earlier. They can allow us to assess a risk beforehand. We talked about this in terms of data analysis. You analyze data, preoperative labs, medical history, surgical variables, the drug history, and you can then identify those patients who are more likely to require surgical intervention and bleeding therapies within the operating room. So if you have patients like that, you can communicate to the blood bank early saying, today I'm going to need more blood products. Please get them in from wherever you need to get them in from. So it improves workflow for the department. It improves collaborative working between hematology, blood bank, the operating room, the anesthesiologist, the surgeon, and it results in better patient care. Blood management algorithms. At the moment, we have on our walls, we have charts of how to treat if your TEG shows this, if your ROTEM shows this. This is the best way to treat, and the interpretation of these curves that the devices generate. The curves are not intuitive. You know, as a doctor, I can understand them because I've been doing them for a long time and I'm an enthusiast about this. But many of my residents look at the curves and think, what's going on? I don't understand. And the value of clinical decision support systems isn't so much for senior physicians. The value of these systems is at 3 o'clock in the morning in the ICU when there's only a junior nurse and a junior resident on board, and they need to be taught how to treat patients, or what's the best way of treating this patient that is bleeding out in front of me. That's where the CDSs really, really help. And because they can be guided by these, the recommendations, and then they can confirm those recommendations with their senior doctors on board. And so timely and personalized intervention is the key thing, 24 hours a day, not necessarily just when the experts are in the hospital on the day. Clinical decision support systems, as I said, will improve blood product management, inventory, so reduce wastage. Blood is an expensive resource. It's rare. A unit of blood, depending on which country you're in, can cost as much as £800. Or FFP is relatively cheap. A cryoprecipitate and platelets are expensive, several £100s per bag. If you reduce the wastage and direct better usage of those, then you can get better stock control and better treatment of those patients that need it. Real-time monitoring is coming back, so that if you can track blood loss in an operating theatre and you can guide clinicians into adjusting transfusion strategies. Some people on bypass, for instance, quite happily run hematocrits of 20, others want to run hematocrits of 27. Why is there a difference? Why do certain patients need certain types of heparin protein dosing. What is the personalization there? Which patients will need better heparin, more heparin because they're developing heparin resistance. If you can track this information real time, you can then treat these patients earlier and more aggressively and get better outcomes for these patients. An outcome prediction, this is what we're talking about. So again, giving blood transfusions to people is not without risk. If you give them blood inappropriately, you're going to get TRALI, you're going to get TACO, you're going to get immune system compromise, and patient outcomes are worse. There's a lot of data that suggests that even if you receive 1 unit of red cells after cardiac surgery, your 5-year outcome is going to be much worse in terms of mortality than it would be without receiving transfusions. So you should only get transfusions if you need them, and not get transfusions if you don't. Post-op management, again, in the intensive care unit, at 3 in the morning, if the physiology is going off and your monitors from your GE systems are showing that the hemodynamic instability is getting worse, what is the next thing to do for that patient? The residents and the nurses need guidance. They need to be told, well, maybe do a TOE, maybe do a TEC, maybe do some lab tests. When do you need to take the patient back for surgery into the operating room? So this is where the guidance of these systems will be more and more helpful, because they'll be able to predict more accurately what is about to happen than currently what happens is when the patient crashes, the CVP goes up to the roof, the blood pressure goes down, and you have to crash the patient back to theatre at the last minute. And integrating all of this data into the medical records allows better data-driven transfusion policies. So as an organization, if you step back from the operating room, as an organization, you get better financial control, you get less wastage, you get better, tighter control of your costs, and you get less variability in care. And so continuous learning from these algorithms allows the systems to refine and become more and more accurate. And this is where the future is heading. There are pitfalls of CDSs, and one of the things we all fear is the loss of physician autonomy. Doctors worry that the systems are going to take over and there's going to be no room for anesthetists in the future. There is going to be a room. We are the ones who are making the final decisions. There is a bit of discussion around who holds the final legal responsibility. So if a clinical decision support system says do X, Y, and Z, and the physician does X, Y, and Z, and the outcome is worse, who holds the final legal responsibility? Is it the company? Is it the CDSS? Or is it the doctor? There's concerns around alert fatigue. So if the alarms go off all the time, inaccurately, what do? We switch them off. And so if you've got a system that is generating too many alarms, then it needs to have its algorithm refined. It's not working as it should be. The integrity of data protection we've talked about, and patient security. This is a big worry in information systems, because there are regulatory issues around Europe passing data to the US passing data to the UK. The cloud system is often based in the US on servers. Who holds that data? Should it go across? And legal aspects of responsibility for that. And then there's user distrust and the relative de-skilling. People worry that, if you have a clinical decision support system guiding you for everything, are doctors going to forget how to do things? And am I going to be de-skilled? And that's a genuine concern as well. And of course, there's the expense of implementing the system in the first place. So if you bring in a new system to the hospital, you look at the financial program that implements that system. Is it going to save the organization money at the end of the day? Because there is the expense of implementing it, there's the expense of maintaining it, there's the expense of training people on these systems. And then if they're not implemented ergonomically, as I said to you before, this disruption in workflow, this is the clear thing that people often buy equipment and you see it sitting in the corner because nobody uses it, because it's there. Somebody somewhere thought it was a great idea to have it, but as doctors, we don't think it's helpful to us, and so we're not using it. So that's the waste. And they require computer literacy. So the future is this: the better quality of care, better patient safety, and better long-term clinical outcomes and survival. This is the benefits of what these systems can offer us. Corresponding change in the platinum blood product use we talked about will lead to financial savings for the organization. And most importantly, you can then create simulation and teaching and education tools. So in the medical school environment, in junior medical staff, junior nursing staff, you can create models and teach them what happens if, what do you do if this happens, or what do you do if this happens? And you can create simulation tools which are very, very helpful. And because these tools are based on validated computational algorithms, their uses are multifaceted. You can put them into better value-based care, which is what every US hospital is now currently looking at. They're looking at cost constraints. And the future is this. This is where it's heading. We use AI-based learning to refine and become more accurate in what we do in our clinical practice. We can look at in patient blood management is the prediction of thromboembolic risk in the ICU patients as well. We can look at different areas of medicine and surgery that will open up to being implemented. So if you look at a physician, if you're doing GI endoscopies, the patients that are going to bleed, the number of varices that they've got, are they more likely to bleed depending on the size of the varices, number of varices? You collect all that data. And then you can predict who's going to likely to require transfusion and who isn't. And there's a huge potential in pre-hospital care, in primary care, wearable technologies. We've got Apple Watches that tell you your blood pressure, your heart rate. You've got systems that measure your blood glucose. Wouldn't it be great if you had a system that could measure from your watch what your coagulation status is? If you need anticoagulation for your heart valve, what's your INR? You don't need to come into hospital doing that. You can sample it from here. So these things are going to be coming. And so just as a final slide, if you like, implementation of change is multi-stage and multidisciplinary. One person can't do it. One or two people can't do it. It has to come from an organization. It has to be multidisciplinary. You have to get buy-in from all these different people. The financial guys, the CFO of the hospital, the physicians, the doctors, us. You have to get us engaged. You have to have evidence show that it works. And you have to measure that once you've implemented the change, has it delivered what you thought it was going to deliver? And the importance of integrating data and analytics into change, I gave you an example of that as patient blood management. So I'm going to stop there. It's 10 o'clock, or nearly 10 o'clock, open to questions and answers. A lot of information there. I hope you're still all awake and open to Q&A. Thank you.